Welcome, my dear future doctors. Today, we are starting one of the most incredible, most fascinating topics in all of medicine, our body's own internal army. This is the first part of our explainer on immunology, and you can think of it as the beginning of Chapter 6 in your textbooks. So get ready and cello, let's jump right in.
So let's start with a very basic question. I want you to just think about it. Right now, at this very moment, you're surrounded by billions, literally billions of germs. So what is stopping you from falling sick every single day? What is this secret protection our body has? The answer, my friends, is our incredible two-part defense system. First, you have the local police, your innate immunity. They're always on patrol, they're super fast, ready for immediate action. But when a really big threat comes along, that's when you call in the special forces, your adaptive immunity. So one is quick and general, the other is a bit slower, but it's precise and absolutely lethal.
All right, so let's properly meet this first line of defense. These are the guards at the gate, the border patrol of your innate immune system. They are always the first ones to face any threat, and believe me, they are always ready.
You see, this first line of defense isn't just one thing, it's a whole multi-layered system. You have physical barriers, like your skin. It's like a big wall, no? Then you have these guard cells called phagocytes, which are like little Pac-Men, just gobbling up any invaders they find. You've also got sentinel cells that raise the alarm and call for help, and even chemical weapons just floating around in your blood, ready to strike.
Now, among these soldiers, there's a true superstar, a real assassin, the natural killer or NK cell. Its mission is very specific, to hunt down our own body cells that have become traitors. Cells infected by a virus or cells that have become cancerous, and to take them out, swiftly and silently. And the way they do this, it's brilliant. The funda is actually very simple. NK cells use a two-checkpoint system. First, they look for stress signals from other cells. Then, they check for a friendly ID card called MHC class 1 that all our healthy cells should have. Now, if a cell is showing stress signals and it's missing its ID card, boom, the NK cell attacks. It's a simple but incredibly effective way to identify compromised cells.
But what happens when the Border Patrol and the local police are just overwhelmed? Well, that's when they make the call. That's when they bring in the big guns, the special forces, the elite warriors of adaptive immunity.
So what makes these special forces so powerful?
Well, there are two key traits. First, they're highly specific. Each soldier is trained to target only one single type of enemy. And second, they have an incredible memory. This immunologic memory is the whole reason vaccines work, and it's why you typically only get a disease like chickenpox once in your life. They never forget an enemy.
Our special forces, they have two main branches. You've got the T lymphocytes, or T cells, and they are for direct hand-to-hand combat. And then you have the B lymphocytes, or B cells. Think of them as the weapons manufacturing division, responsible for long-range attacks by making these guided missiles we call antibodies. Let's just break down the T cells for a second. You have helper T cells, who act as the commanders. They coordinate the entire attack. And then you have the cytotoxic T cells. These are the assassins who directly go and eliminate infected or cancerous cells from the body. And B cells? Well, they are the weapons factories. When they get activated, they become something called plasma cells. And these are just antibody-producing machines. They can churn out thousands of antibodies per second. These antibodies then flood your entire system, relentlessly hunting for their one specific target. Okay, so this brings up a very critical question. How do these powerful T cells know the difference between a friend and a foe, between a healthy body cell and an infected one? I mean, a mistake here could be absolutely disastrous, right? The answer is a super sophisticated ID card system called the Major Histocompatibility Complex, or MHC. In humans, we have a special name for it, the HLA system. Just think of it like a billboard on the surface of every single cell. And this billboard displays little pieces of proteins from inside the cell, showing the immune system exactly what's going on.
Now, please pay attention. This part is very important for your concepts. There are two types of these ID cards. MHC class 1 is on almost every cell in your body, and it shows what's happening inside that cell. MHC class 2, on the other hand, is only on special immune cells, and it shows what those cells have captured and eaten from the outside. And each card is scanned by a different type of T cell.
So think of class 1 MHC as a live status report from every cell. If a virus invades a cell, for example, fragments of the viral proteins are immediately put up on the MHC class 1 billboard. This is a direct signal to the assassin T cells, we also call them CD8 plus T cells, that this cell is compromised and it needs to be destroyed.
And class 2 MHC? It's like a trophy case. When a professional immune cell eats a pathogen, it breaks it up and displays the fragments on its MHC class 2. This is like showing off a trophy to alert the commander T cells, the CD4 plus T cells, that a dangerous enemy is present, and it's time to launch a major counterattack.
All right, so every army needs its bases and its training camps, doesn't it? Our immune system is highly organized. So where are all these amazing cells trained and where are they stationed? Let's find out. So we have what are called primary lymphoid organs, which are like the military academies. This is the bone marrow where B cells mature and the thymus where T cells mature. And then we have the secondary organs, which are like the army barracks scattered all over the country. These are your lymph nodes, your spleen, where the fully trained soldiers are deployed and just wait for action. And just look at this beautiful slide. This is what a lymph node looks like inside. It is not random at all, Yar. You can see the B cells, here in green, are neatly organized in these structures called follicles, and the T cells in red are in a separate area right next to them. This is a perfect strategic design, a meeting point where commanders and weapons makers can coordinate their response. So what is the crucial point here? It's this. The immune system is not just a random collection of cells. It is a highly coordinated masterpiece. From the border guards of the innate system to the elite special forces to the command centers where they all meet, it all works together in this beautiful synchronized dance of detection, communication, and finally elimination. This leaves us with one final and very crucial thought. Our immune system is incredibly powerful, but what happens when it turns on us? What happens when this very army starts attacking our own healthy tissues? Well, that's the basis of autoimmunity, and we'll explore that very important question in our next explainer. Thanks for joining me.
Hello, everyone. So today we're going to talk about something really fascinating. You know, what happens when our body's own defense system, our own immune army, makes a terrible mistake? It's basically a case of friendly fire, but the consequences, they can be very, very serious.
So let's start with a question. A puzzle, really. I mean, have you ever wondered, why can something as harmless as a peanut or even a simple bee sting cause a full-blown, life-threatening reaction in some people? It doesn't make sense, right? Well, by the end of our discussion today, we are going to solve this puzzle.
Okay, so this is our roadmap for today. First, we'll look at how our immune cells even talk to each other. You can think of it like their own private WhatsApp. Then, we'll meet the two main divisions of this immune army. After that, we'll see what happens when this defense goes completely wrong. And finally, we'll really break down an allergic attack. See how each topic builds on the last? So, pay close attention. Chalo, let's begin.
Right, so first things first. If we want to understand a battle, we first have to understand how the soldiers communicate, correct? How does one part of the immune system send a message all the way to another part, saying, hey, we have an invader over here, get ready?
Well, the answer is these amazing molecules called cytokines. Just think of them as the WhatsApp messages of our immune system. They're basically these tiny proteins that cells secrete to send signals to other cells. It's that simple, nah? They are the interleukins. The name itself says it. Inter means between, and leukin for leukocytes, or white blood cells. So messages between white blood cells. This is how they coordinate the entire attack.
And listen, these messages are not all the same, okay? Some are like an urgent intruder alert that activates the first responders, the innate immune system. Others are like a command, telling the elite forces, the lymphocytes, to multiply and get ready for a specific fight. Then you have messages that call for reinforcements, literally telling the bone marrow to produce more white blood cells. And very importantly, there are also messages that say, okay, boys, job is done, stand down. They terminate the immune response.
Acha, so now we know how they talk, let's actually meet the soldiers. Let's meet the two main divisions of our elite force, the adaptive immune army, the T cells and the B cells.
Now, the most important thing to understand is that their strategies are completely different. The T cells, they are like your army's special forces, the commandos. They do hand-to-hand combat, going after microbes that are hiding inside our own cells, like viruses. The B cells, on the other hand, are like the Air Force. They don't go to the battlefield themselves. They fight enemies that are outside the cells, floating in the blood or body fluids, by launching these long-range missiles we call antibodies.
So here you can see the T cell strategy in action. These naive or untrained T cells, they first get their orders in a command center, which is usually a lymph node. Once they are activated, they travel directly to the site of infection and eliminate the infected cells one by one. It's a very direct, very personal, and very efficient approach.
Now just compare that with the B cell strategy. Instead of traveling to the fight, the B cells transform into these amazing little antibody factories called plasma cells. They often stay put, maybe in the lymph node or spleen, and just pump out millions and millions of these antibody missiles into the blood. These antibodies then travel and find the enemy, neutralizing them from a distance. So you see, two totally different but equally important ways of fighting.
Okay, so we have this incredibly powerful, very well-coordinated army. But what happens when this army overreacts? What happens when it sees something totally harmless, like a grain of dust or pollen, and mistakes it for a deadly invader? Well, this brings us to the core of our topic today, hypersensitivity.
And this is the most important concept to get right. Hypersensitivity is not the immune system failing. It is actually the immune system working too well or being overzealous. The reaction is excessive, it's poorly controlled, or it's aimed at the wrong target, sometimes even our own body's cells. And it's this collateral damage that actually causes the disease.
Now, this overreaction can happen in 4 main ways, and we classify them as type 1, 2, 3, and 4. Type 1 is your classic allergy, the one we all know. Type 2 is when our antibodies attack our own cells. Type 3 is when these antibody-antigen clumps get stuck in our tissues and cause trouble. And type 4 is driven by our T cells, the commandos. For today, we are going to focus mainly on type 1, and then we'll briefly look at type 2, just to see the contrast.
All right, so let's really dive deep into the most common one, type 1 hypersensitivity. This is what we all call an allergy, and by understanding this, we will finally solve our original puzzle about the peanut. You can think of an allergic reaction like a 2-act play. Act 1 is called sensitization. The first time you're exposed to an allergen, let's say some pollen, your body says, what is this? And produces a special type of antibody called IgE. These IgE antibodies then go and stick themselves onto cells called mast cells. Now during this first act, you feel nothing, 0 symptoms. The stage is just being set. But then comes Act 2. Re-exposure. The next time that same pollen enters your body, it finds those IgE antibodies waiting on the mast cells, latches on, and boom! The mast cells are triggered and they release a massive flood of powerful chemicals. That's when you get the reaction.
And believe me, these mast cells are the key players, the main culprits here. They are literally like landmines scattered all throughout our tissues, especially where we meet the outside world, like our skin, our lungs, and our gut. The IgE antibodies act as the trigger plates on these landmines. So the mast cells just sit there, completely armed by IgE, just waiting for the allergen to come and step on them.
Okay, but the story doesn't end there. This allergic attack isn't just one single explosion. It actually comes in 2 distinct waves. First, you have the immediate reaction, which happens within minutes. But then, there's a second, delayed wave called the late phase reaction, which can start hours later.
So what's the difference? Well, the immediate reaction is caused by pre-stored chemicals like histamine that are released instantly from the mast cell. This is what gives you all those classic symptoms we know, the runny nose, itchy eyes, sneezing, that sort of thing. The late phase reaction, however, is different. It involves the mast cells sending out those cytokine messages to call in more inflammatory cells, especially these guys called eosinophils. And they are the ones who cause more prolonged inflammation and actual tissue damage. This is what explains why a condition like asthma isn't just a brief sneezing fit, it's a chronic inflammatory disease.
And this micrograph here, this gives you a real look at that late phase reaction. This is a biopsy from a patient. You see all those bright red or pinkish cells? Those are the eosinophils we were just talking about. They've been recruited into the tissue hours after the initial allergic exposure, and it's their presence that's causing all that ongoing damage and inflammation.
So when that mast cell degranulates, what exactly does it release? It's not just one thing. It's a whole chemical cocktail, a powerful arsenal. First, you have the preformed mediators, like histamine, which are already packed in granules, ready to be released instantly. Then, the mast cells start synthesizing brand new lipid mediators, like leukotrienes. And these are thousands of times more potent than histamine. And finally, it releases cytokines, or WhatsApp messages, to call in reinforcements for that late phase reaction. It is a truly devastating arsenal.
Okay, so that was type 1, the classic allergy. Now, let's just briefly look at another way antibodies can cause injury, which is completely different from what we just discussed. This is type 2 hypersensitivity.
In this case, the problem is not mast cells. Here, the antibodies, usually IgG or IgM, they bind directly to antigens on the surface of our own cells, for example, a red blood cell. This antibody coating acts like a big "eat me" sign. It marks the cell for destruction, and then phagocytes come along and gobble it up, or the complement system gets activated and just lyses the cell. This is the mechanism behind diseases like autoimmune hemolytic anemia, and it's exactly what happens in a mismatched blood transfusion.
So, after going through all of that, what's the big takeaway? What is the moral of this whole story of immunity and hypersensitivity?
Well, it all comes down to one word: balance. The very same immune mechanisms, the same cells, the same antibodies, the same cytokines that protect us from deadly infections, when they get out of balance, they can cause a life-threatening allergic reaction or a debilitating autoimmune disease. You see, pathology is often just normal physiology happening in the wrong context or at the wrong intensity. And understanding this fundamental principle is the absolute key to treating these diseases.
And I will leave you with a final thought to ponder, something for you to read up on. It's called the hygiene hypothesis. The idea is this: could our ultra-clean, modern, sanitized environments actually be preventing our immune systems from getting a proper education in childhood? Is it possible that without exposure to enough dirt and germs and real threats to fight, our immune system gets, well, bored and starts overreacting to harmless things like peanuts and pollen? This could be one reason for the explosion of allergies we are seeing today. It's a fascinating idea and something for you to think about before our next class.
Hello, my dear students, and welcome. Today we're diving into a very important topic, a real thriller from inside our own bodies. We're going to explore the absolutely fascinating and, let's be honest, kind of frightening world of hypersensitivity and autoimmunity. So I want you to imagine your immune system as your own personal bodyguard, right? On duty 24/7. Its only job is to protect you. But what happens when that bodyguard gets confused, when it starts attacking you instead of the real bad guys? Well, that, in a nutshell, is the tragedy of hypersensitivity and autoimmunity. It's friendly fire, but on a microscopic scale. Cello, let's start with the first way our bodyguard messes up. We're going to focus on the antibodies. Think of them as the immune system's first responders. They are super specific, super effective, but sometimes they can be dangerously misguided.
Okay, so in what we call type 2 hypersensitivity, the antibodies go and directly attack our own healthy cells. They basically latch onto the surface of a cell and paint a giant target on it. The rest of the immune system sees this target and, well, it destroys the cell, thinking it's an enemy. It's a direct, targeted hit, a classic case of mistaken identity.
Now look at this table. This is what's so fascinating. The outcomes can be so different. For example, take Graves' disease. Here, the antibody doesn't kill the cell. No, it actually stimulates the TSH receptor. It's like it's putting its foot on the accelerator of the thyroid, causing hyperthyroidism. So you see, these misguided antibodies can block, they can stimulate, or they can mark for destruction. They're incredibly versatile weapons, for sure.
So the crucial point is this: type 2 is a sniper attack. One antibody, one specific target. Very precise. But now let's look at type 3, which is a completely different beast altogether. It's less like a sniper and more like a bomb going off in the wrong place, causing all sorts of collateral damage. You see, in type 3, the problem isn't the antibody attacking a cell directly. The problem is that these little packages of antigen and antibody, we call them immune complexes, which should be harmlessly cleaned up, instead get deposited in our tissues. They get stuck in blood vessels, in the kidneys, and joints. And that's where they start a riot. The cleanup crew itself is causing the mess.
The funda is very simple, really. It happens in 3 phases. First, you get the formation of these antigen-antibody complexes in the blood. Second, you get deposition. They get lodged somewhere they shouldn't be. And third, once they're stuck, that's when the real damage happens. Inflammation, a massive inflammatory response.
And this diagram, this illustrates the process brilliantly. See? These complexes, once they're deposited, they act like little magnets for neutrophils. The neutrophils rush in, all ready for a fight, and they release their destructive enzymes. But the problem is, there's no real enemy to fight. So they end up damaging our own blood vessels, leading to something called vasculitis. This is the core mechanism behind diseases like SLE, systemic lupus erythematosus.
So far, we've been talking about B cells and their antibodies. But what happens when the immune system's ground troops, the T cells, get the wrong orders and decide to revolt? Now, let's move on and see what happens then.
This is called delayed type hypersensitivity, or DTH, for a very simple reason. The reaction takes time. It's not fast like an antibody reaction. No, this one takes about 24 to 48 hours to really show up. It's an attack orchestrated by our special forces, the CD4 plus helper T cells and the CD8 plus cytotoxic T cells.
Now what's really interesting about this slide is that you can actually see the cellular culprits. On the left, you see the general inflammation. But look on the right, with the special staining, those brown cells you see, those are the CD4 plus T cells, the ringleaders of this whole riot, coordinating the attack. Samajh mein aaya?
Okay, so we've seen the what, the different ways our immune system can cause damage. But now let's get into the much more difficult question, the why. How is the bodyguard even trained to tell friend from foe in the first place? And why does that training sometimes fail so spectacularly?
The entire system is built on this one single principle: immunologic tolerance. It is the ability of your bodyguard to recognize you, to know what is self and what is non-self. This is not an optional feature, okay? It's the most basic fundamental property of a healthy immune system.
So how is this tolerance achieved? Well, our bodyguard goes through two very distinct training programs. First, there's a really rigorous boot camp when the lymphocytes are young, and this is called central tolerance. And then there's a continuous set of rules they have to follow when they're out in the field, which we call peripheral tolerance.
So, central tolerance is the boot camp. It happens in the thymus and the bone marrow. And here, any young T or B cell that reacts too strongly to our own body's cells, it gets eliminated. It's a process called negative selection. Peripheral tolerance, on the other hand, those are the rules of engagement for the cells that graduate and make it out into the body. It's the backup system to neutralize any rogue agents that might have slipped through the boot camp.
And out in the field, there are multiple backup systems. A self-reactive cell can be rendered unresponsive, put into a state called anergy. Or it can be actively suppressed by a special police force of T cells called regulatory T cells, or TREGs. And finally, if all else fails, it can be ordered to commit suicide through apoptosis. So you see, there are multiple layers of security.
So this brings us to a really critical point. Autoimmunity rarely, if ever, happens because of one single failure. The system is just too robust for that. Instead, it's more like a perfect storm, a terrible combination of bad luck and bad timing where multiple safeguards fail all at once.
First, you need a genetic predisposition. Think of this as the bodyguard having some kind of pre-existing vulnerability. The most important genes involved here are the HLA genes. For instance, if you inherit the HLA-B27 gene, your risk for developing ankylosing spondylitis is 100 to 200 times greater. It doesn't cause the disease, mind you, but it definitely sets the stage.
And then an environmental trigger comes along, usually an infection. This is where a phenomenon called molecular mimicry can happen. Imagine a bacteria has a protein that looks very similar to a protein in your own heart muscle. Your bodyguard mounts this powerful attack against the bacteria, but it gets confused. And in its zeal to kill the bacteria, it starts attacking your heart too.
In this slide, this brilliantly illustrates how it happens. Look at panel A. The infection causes so much inflammation that it just supercharges the local immune response, and tolerance breaks down. And in panel B, you can see molecular mimicry in action, where the microbe itself looks just like one of our own cells, tricking the immune system into this cross-reactive attack. It's a really deadly combination of bad genes and bad luck. So let's bring it all together. What is the final diagnosis for you, the future doctors? What are the key things you really need to take away from all this?
Here are the 3 things you absolutely must remember. First, tolerance is the normal default state. Our immune system is designed not to attack us. Second, a failure of this tolerance is the root cause of all autoimmune disease. And third, this failure is almost never a single event. It's a complex interplay between your genes and your environment. As the saying goes, genes load the gun, but the environment pulls the trigger.
I will leave you with this final thought. It's something for you to ponder as you continue on your journey to becoming clinicians. When the body is at war with itself, there is no foreign enemy to defeat. There are only casualties. And treating that, well, that is one of the greatest challenges in modern medicine. Thank you. Hello, everyone, and welcome. Chalo, let's get started. Today, we are going to tackle a really fascinating topic in medicine, something that can be quite confusing: autoimmunity. We're going to talk about what happens when the body's own defense system, its own army, gets confused and starts attacking itself. So this is our lecture plan for today. First, we'll understand what autoimmunity actually is. Then we'll take a deep dive into lupus, which you'll see as a classic example. We'll look at how to diagnose it, what causes it, the damage it does, and finally, we'll see how it's related to other similar diseases. Simple, right? Let's begin. Okay, so first things first. Before we can even begin to talk about specific diseases like lupus, we need to understand the fundamental problem, the basic mistake that the immune system is making here. It's a massive failure of recognition, really.
Just imagine this for a second. Your body has an army, right? The immune system. Its only job is to protect you from outsiders, bacteria, viruses, all the bad guys. Now, what happens if this army suddenly declares war on its own country, on you? It starts seeing your own healthy cells as the enemy. It's not just a small mistake, it's a complete betrayal from within. This, my friends, is the core idea of autoimmunity.
So, the proper term for this is a failure of self-tolerance. Think of your immune system like, say, the security guards for a very important building. From day one, they're trained to recognize everyone who works there. You're friendly, you belong here, they know the self. Autoimmunity is what happens when these guards suddenly get confused or their programming gets corrupted. They can't tell the difference between a friend and an enemy anymore and start attacking everyone.
And look, this is not just a one-time mistake. It's actually a terrible chain reaction. The first attack damages some cells, right? When those cells break open, new proteins from inside them spill out. These are self-antigens the immune system hasn't seen before. So what happens? The immune system says, "Hey, who are these new guys?" and launches a new attack on these new targets. It's a vicious cycle that just keeps getting worse. This is a very important concept called epitope spreading, and it's why these diseases don't just go away.
All right, now that we have the theory, let's look at a real-world example. Our main case study today is systemic lupus erythematosus, or as we all call it, SLE. Now, listen carefully for all of you future doctors. Understanding lupus is non-negotiable. It is the perfect textbook example of a systemic autoimmune disease.
Let's just break down the name itself. Systemic, that means it's not just in one place. It affects the entire system, the whole body. Now, what is the weapon being used? The body's making a whole range of autoantibodies, antibodies against itself. And the main target? The nucleus of our own cells, the command center. The immune system is literally attacking the brain of its own cells. Now look at this number, 9:1. What does this mean? It means for every one man diagnosed with lupus, 9 women are, especially during their childbearing years. This is a huge clinical clue. Whenever a young female patient comes to your clinic with a bunch of vague, strange symptoms, you must have lupus on your differential diagnosis list. Remember this.
And there's a very good reason we call it the great imitator. It's like a master of disguise, a real chameleon. Sometimes it starts with a bang, very suddenly. Other times it just creeps up on you slowly. Patients will have good periods and then bad periods. We call it relapsing and remitting. And just look at the symptoms it starts with. Fever, joint pain, rash, tiredness. I mean, this could be anything, right? It could be the flu, it could be stress. This is what makes diagnosing lupus so incredibly difficult.
So the question is, how do we catch this great imitator? How do we unmask it? Well, you have to become a bit of a detective. The patient's history is your first clue, of course, but the final proof, the smoking gun, that's in the lab reports, specifically in the blood work.
The first and most important test you will order is for anti-nuclear antibodies, or ANAs. This is your screening test. It's simple. If the ANA test is negative, it is highly unlikely that the patient has lupus. But if it's positive, aha, now our investigation begins. We then have to look at the pattern of the ANAs. This pattern tells us which part of the nucleus is under attack. Okay, look here. This is the first main pattern. It's called the homogeneous pattern. See how the whole nucleus is glowing a smooth, uniform green? There are no spots, no speckles, just a solid glow. This tells you that the antibodies are attacking the very core material of the nucleus, the DNA and chromatin. This is a very common finding in SLE. Classic, in fact.
Now, look at this one. It's totally different, isn't it? This isn't smooth at all. It's got these little dots, these speckles. This is the coarse speckled pattern. What is being attacked here? It's the machinery that processes RNA. And if these speckles are because of antibodies against something called the Smith antigen, then you've basically confirmed the diagnosis. Anti-SM is highly specific for lupus.
And here's a third pattern just to show you how useful this is. Again, it's different. See these very distinct, separate dots? This is the centromere pattern. Now this is a big clue. While you might see it sometimes in lupus, this pattern really screams another disease called systemic sclerosis, particularly the CREST syndrome type. So you see, these patterns help us not just diagnose SLE, but also to tell it apart from its cousin.
Okay, pay attention now. For your exams and, more importantly, for your clinics later, these are the 3 antibodies you absolutely must know for lupus. First, anti-dsDNA. It's specific for SLE, and it's a red flag for kidney problems. Second, anti-SMEM. Like we said, this one is your diagnostic lock. It's very specific. And third, anti-phospholipid antibodies. If you see these, you have to worry about the patient forming dangerous blood clots.
All right, so now we know how to diagnose it. We can find the clues. But the bigger question is, why? Why does this even happen? Let's try to connect the dots now. We'll look at the genes, the environment, and see how this whole mess starts. This is the pathogenesis.
So here's how the story goes. It starts with a trigger. A very common one is UV light from the sun. This causes some of your cells to die, which is a normal process called apoptosis. But here's the problem. In people who have the lupus genes, the garbage disposal system of the body is faulty. The cleanup crew is slow, so all these dead cells and their nuclear parts, the DNA and proteins, are left lying around. Now the immune system, which should ignore this stuff, sees it and gets activated. B cells and T cells start producing those ANAs we saw earlier. And then it gets worse. These antibodies and antigens form complexes, and these complexes are like fuel on the fire. They superactivate the immune system, and the whole cycle just keeps going and going on its own.
Okay, so we've covered the why, we understand the mechanism. Now let's look at the what. What is the result of all this? How does this out-of-control immune system actually damage the body from head to toe?
This is a perfect example. On the left, you see what the patient sees in the mirror, the classic butterfly rash on the face. It's a hallmark sign of lupus. And on the right, that's what we see under the microscope. All those little purple dots are immune cells. They are lining up and attacking the junction between the top layer of skin and the layer below it. This microscopic battle is what causes the visible red inflamed rash. And the attack is not just on the skin. Remember those immune complexes we talked about? They can get stuck anywhere in the body, including the valves of the heart. When they do, they can cause something called Liebman-Sachs endocarditis. See these small, warty-looking things on the valve? These are called vegetations. But unlike in infections, they are sterile. There are no bacteria. This is a very characteristic finding in SLE and can cause serious heart issues. And the damage doesn't stop there. The kidneys are a huge target. In fact, lupus nephritis is one of the most serious complications. The joints get inflamed and painful. The immune system can attack blood cells, causing anemia or low platelets. It can even affect the brain, causing neuropsychiatric problems, and the linings around the lungs and heart can get inflamed, pleuritis and pericarditis. This is what we mean when we say systemic. It's everywhere. Okay, so to wrap things up, let's just zoom out for a minute. Everything we've learned about lupus is very, very useful. Why? Because lupus isn't alone. It's part of a bigger family of related autoimmune diseases, which we often group together as connective tissue diseases.
This table is a really nice summary. You see, while SLE is the big multisystem disease, you have its cousins. For example, Sjogren's syndrome, which mainly attacks the tear and saliva glands, so patients get very dry eyes and a dry mouth. Then there's systemic sclerosis, where the main problem is fibrosis or scarring, which makes the skin really tight and hard. And you can see each one has its own key symptoms and its own specific antibodies that help us make the right diagnosis.
So I want to leave you with one final thought. The immune system is an incredibly intelligent and specific weapon, isn't it? In these diseases, that weapon has been turned around to attack us. But think about this. If it can be programmed so precisely to attack, could it one day be reprogrammed to heal? If we can truly understand how it goes wrong, maybe one day we can learn to fix it, to teach it tolerance again, and find a real cure. That is the challenge for your generation of doctors. That is the future. Thank you.
Good morning, everyone, and welcome back to our class. Today, we are finishing our series on the diseases of the immune system. We're going to explore what happens when this amazing system, our body's own army, goes rogue. So, let's jump right in, shall we?
So let me ask you a question to start. We always think of our immune system as our personal bodyguard, isn't it? But so, Cho, what happens when this bodyguard gets confused and starts attacking us? Or what if it attacks a life-saving kidney transplant, seeing it as some foreign enemy? This is the very puzzle, the paradox, we'll be exploring today. All right, here's our plan for the day. Some very, very high-yield topics, so please listen closely. We'll start by looking at what happens when tissue hardens. Then we'll get into the whole drama of transplant rejection and its timeline. After that, a very curious case where the transplant itself attacks the host. And finally, we will see what happens when you are born with a faulty immune shield.
Chalo, our first case file. Just imagine the body's healing process goes completely haywire. Instead of just patching up an injury, it just keeps building and building scar tissue everywhere. This, my friends, is fibrosis, a hardening of our tissues, and it's a key feature of so many autoimmune diseases. Now look at this under the microscope. On the left, you see beautiful normal skin with all its nice organized layers. But on the right, sclerodermy, that is systemic sclerosis. Just look at how the dermis is completely choked with that dense pink collagen. The normal structures, the hair follicles, the glands, they are almost completely gone, erased. This is fibrosis in action. And here you see the real-world result of what you just saw on that slide. That fibrosis pulls the skin so tight that the fingers are frozen into this painful claw-like shape. The blood supply is cut off, causing these terrible sores. This is why we study pathology, Bachelog. It's not just about looking at pictures, it's about understanding a patient's suffering.
Now, another condition you must always keep in mind when you see fibrosis is IgG4-related disease. It's a real chameleon, it can appear in almost any organ. The key here is that the tissues get flooded with plasma cells, making these IgG4 antibodies, which then causes, you guessed it, more and more fibrosis. Please remember this one. It's a master of disguise.
Okay, let's shift gears to our next case file. Transplantation. A modern miracle, for sure, nah? But here is the catch. To your immune system, that new kidney is not a gift. It is a foreign invader. And the immune system, well, it has only one job: destroy all invaders.
First, some key terminology. A transplant between two different people is called an allograft. This is what we see in the clinic every single day. And because no two of us are genetically identical, unless of course you are an identical twin, the body will always see this allograft as foreign.
So what exactly is screaming foreign to the body? It's these molecules, human leukocyte antigens, or HLA. The simplest way to think of them is like a molecular ID card on all our cells. You can think of it like an Aadhaar card for your cells. If the donor's ID card doesn't match the recipient's, the body's security guards, the T cells, they sound the alarm.
So how does this alarm become a full-blown attack? Well, first, your T cells recognize the foreign ID card. Then they attack in two main ways. Either directly, T cell versus graft cell, face-to-face combat, or indirectly by recruiting more T cells to amplify the assault. But the final step, sadly, is always the same: destruction of the organ.
Now this rejection, it isn't a one-size-fits-all problem. No, it happens on different timelines, and you must know the three patterns: hyperacute, acute, and chronic. Remember this for your exams. The timing tells you everything about the mechanism.
Okay, this is a 5-star, high-yield slide. Take a screenshot of this one, write it down. It boils everything down for you. Hyperacute is immediate, within minutes, and it's driven by preformed antibodies. Acute happens over days to weeks, led by T cells. And chronic, that's a slow burn, over months to years, leading to fibrosis. Onset, mediator, pathology, you must know this table inside and out.
This is what hyperacute rejection looks like. It is a complete vascular catastrophe. Pre-existing antibodies in the patient's blood attack the new organ's blood vessels instantly, on the operating table itself. You see those dark red clumps? Those are blood clots, thrombosis, choking the life out of the kidney. The organ is dead before the surgery is even finished.
Next up, we have acute rejection, happening a few weeks later. Look closely at this blood vessel. You see those little dark blue dots? Those are the patient's own T cells, their own soldiers, attacking the vessel from the inside. This inflammation is called endotheliitis, and it is a classic textbook sign of acute rejection. And finally, we have the slow killer, chronic rejection. This can take years. The vessel wall here has become so thick with scar tissue, look, that the opening for blood, the lumen, is almost completely gone. It's a slow, smoldering immune attack that gradually strangles the organ. And this is why, sadly, so many transplants eventually fail over the long term.
But wait, there is one more twist in this story. We always talk about the patient's body rejecting the organ, no? Host versus graft. But what if? What if the organ or the graft attacks the patient? This is exactly what can happen in a bone marrow transplant. The transplant itself goes on the attack.
This slide makes it very, very clear. Normally, it's host versus graft. Your body attacks the new organ. But in graft versus host disease, or GVHD, it's the complete opposite. The immune cells from the donor's graft attack your body. It's like inviting a guest into your home only for them to turn on you and try to burn the house down. It's a truly dangerous situation.
And here is the proof, the smoking gun. In this skin biopsy, you can see the donor's T cells all lined up attacking the patient's own skin cells. This is what causes the terrible rashes you see in these patients. And this same attack can happen in the gut, in the liver. It's a full-body assault by the donated cells.
For our final case file today, let's flip the script completely. We've seen an immune system that is too active, that is overreacting. But what if it's underactive? Or what if parts of it are missing altogether? This brings us to primary immunodeficiencies. And when you see what happens without this shield, you truly understand its value.
Here are 4 big ones you must know for your exams. SCID is the most severe, no B cells or T cells. In X-linked agammaglobulinemia, there are no antibodies. D. George is a T cell problem because the thymus doesn't develop. And in CGD, your cells can eat the germs, but they can't kill them. Each of these diseases teaches us something vital about how our immune system works.
Let's just look at one classic example. X-linked agammaglobulinemia. The whole problem is a broken enzyme called BTK. This enzyme is a key part of the B cell factory assembly line. Without it, the line just shuts down. And the result? No mature B cells, which means no antibodies to fight infection. It's as simple as that.
What's so fascinating about SCID is that many different genetic mistakes can all lead to the same tragic outcome. It could be a faulty receptor that blocks T cell growth, or it could be a missing enzyme that causes a toxic buildup that kills the lymphocytes. But the end result is the same, a total collapse of the immune system. So, to wrap everything up, I want you to hold on to this one image. The immune system is constantly walking a tightrope. On one side is defense, on the other, destruction. Too little action, you have immunodeficiency. Too much action, you get autoimmunity and rejection. It is all about finding that perfect balance. And this brings me to my final question for you. This isn't just theory from a textbook, okay? This is the core of medicine. Your job as a doctor will be to manage this balance every single day for your patients. So I will leave you with this to think about. How will you help your patients walk this tightrope? Thank you very much for your attention.
All right, everyone, settle down, settle down. So we always talk about our immune system like it's this amazing fortress, right? It's got walls, it's got soldiers, commanders, the whole shebang, all there just to protect you. But what happens when the fortress itself begins to fail, when the walls start crumbling? That's the big, critical question we're going to tackle today. I mean, really think about it. What happens when your own army just vanishes? The soldiers disappear, the commanders go on leave, the weapons factories just shut down. Well, that is the reality of immunodeficiency. And understanding this, I promise you, is not just for your exams. This is real-world, life and death stuff that you will see in the clinic. So, Cello, let's get into it. Very broadly speaking, we can put these failures into 2 big buckets. First, you have your primary immunodeficiencies. The easiest way to think about this is that the fortress was built with a faulty blueprint. Right from day one, there was a manufacturing defect. It's a genetic and inherited problem. And then you have the secondary immunodeficiencies. Now, these are far, far more common. In this case, the fortress was built perfectly, but it got damaged later on in life. It was damaged in battle. Okay, so let's first look at a few classic examples of these faulty blueprints. Now, listen, these conditions are rare, okay? You won't see them every single day. But, and this is a very important but, studying them teaches us so much about how all the different parts of our immune system are supposed to work together. It's like looking at the engine schematic. First up, X-linked agammaglobulinemia. Big name, simple concept. What's happening? It all boils down to a single faulty gene, a gene called BTK. And just because of this one tiny flaw, the B cells, well, they just can't grow up. They fail to mature. Now you tell me, what do mature B cells become? Plasma cells, exactly. And what is the job of a plasma cell? To pump out antibodies. So you see the domino effect? No good BTK gene means no mature B cells, which means no plasma cells. And that means 0 antibodies. The fortress has no weapons factory. Simple as that. Now this next one, DiGeorge syndrome, is absolutely fascinating because of the organ it involves. Here, a tiny little piece of chromosome 22 goes missing. It's deleted. And this tiny little deletion, it means the thymus gland, it just doesn't develop properly. And what is the thymus? It's the training academy. It's the military college where our T cells mature. So no thymus means no trained T cells. And if you have an army with no generals to give orders, what do you have? You have chaos. And our last primary example is hyper-IgM syndrome. This one is a bit more subtle, you see. The B cells are there, they're making antibodies, but only the most basic kind, IgM. The problem is they can't upgrade their weapons. You see, the T cells are supposed to give a very specific signal using the molecule called CD40L that tells the B cells, okay, time to class switch, bring out the big guns, IgG, IgA. In this disease, that signal is broken. The army is stuck with only basic pistols when it really needs machine guns and rocket launchers. Okay, so those were the manufacturing defects. Now let's talk about the much more common scenario, the fortress that was built perfectly well but got damaged later. These are the secondary or the acquired immunodeficiencies. And believe me, these are the cases you will see again and again in the hospital. And the causes for this are, well, all over the place. Something as fundamental as malnutrition can cripple your immune system. Cancers that go into the bone marrow, they're attacking the factory where the immune cells are made. Even our own treatments for cancer, chemo, radiation, they cause collateral damage. But among all these causes, one of them, it stands in a class of its own for its global devastation. And this is where our fortress analogy becomes genuinely chilling. We're now talking about a virus so clever, so insidious, that it doesn't just bang on the fortress walls from the outside. No, it's a spy. It sneaks inside, finds the main command center, and hijacks the entire operation from within. We are, of course, talking about HIV. So for the rest of this lecture, we are going to focus entirely on this one virus. Because mark my words, to understand HIV is to understand the most profound, most intelligent example of immunodeficiency known to medicine. This is absolutely critical stuff. And before we get into the nitty-gritty, just look at this number. Let it sink in. By 2021, an estimated 40 million people had died from AIDS-related illnesses. That's not just a statistic, it's a global tragedy. That is the magnitude of the problem we are dealing with. So, what is the secret to this virus's terrifying success? It's all about the target. It is laser-focused. It targets one cell above all others, the CD4-positive helper T cell. Now remember, this is not just some foot soldier, this is the master regulator, the general that coordinates the entire immune response. So by targeting the general, HIV doesn't just fight the army, it decapitates it. So how does it do this? It's a beautiful and terrible 5-step hijack. First, it docks onto the T cell. Then, it uses a very special enzyme to reverse transcribe its own RNA into DNA. Now, here comes the masterstroke. It permanently integrates that viral DNA right into the host cell's own genome. The T cell is now a hostage. Its own machinery is tricked into making new virus parts, which then bud off and go on to infect even more cells. And here is the most diabolical part of its entire strategy. The virus can just lie there, sleeping, dormant inside the T cell's DNA for years. So what wakes it up? You won't believe it. It wakes up when the T cell itself gets activated to fight some other infection. The very same alarm signals that tell a T cell, hey, wake up, do your job, are the same signals that switch on the HIV genes. So the body's attempt to fight back actually fuels its own destruction. It is a complete subversion from within. So this whole process leads to a very distinct clinical story. First, in the acute phase, you get a burst of virus, some flu-like symptoms. Then, the immune system fights back, and you enter a long, silent phase of clinical latency. For years, the patient can feel totally fine. But under the surface, a war is going on. The CD4 cells are being steadily destroyed. And finally, when the CD4 count drops below that critical level of 200, the fortress collapses. This is AIDS. And now all sorts of opportunistic infections take over. Okay, so that's all fascinating pathology, I know. But how does this translate to your life in the clinic? Why does understanding all this detail actually matter when you have a patient sitting in front of you? Let's connect this theory directly to your practice. So here are your take-home points. Number 1. When you see a patient with infections that are too frequent, too severe, or just plain weird, your mind must think about immunodeficiency. Number 2. For your HIV patients, the CD4 count is king. It is the single best gauge of how strong the fortress is. 3. Remember the mechanism. HIV is a battle of attrition. It is actively destroying the generals. And finally, number 4. This is why our modern antiretroviral drugs work so well. They are all designed to throw a spanner in the works of that viral life cycle we just talked about.
So I will leave you with this final thought. We have spent today talking about the science of how a fortress fails. But your job as a doctor is not just to be a scientist, it's to be a healer. The real challenge is to stand with your patients and use this knowledge not just to diagnose the problem, but to help them rebuild their defenses piece by piece. Think about that.
Shuttle friends, let's begin today's class. You know, in medicine, we're usually fighting enemies from the outside: bacteria, viruses, injuries. But today, we're going to talk about something a little different, something more internal. We're going to explore what happens when the body's own fundamental systems completely fail. It's a tale of two very different but equally devastating collapses.
So this is the main question for today. Just think about it for a second. What happens when the very army that's supposed to protect you just crumbles? And what if the very bricks you're using to build your house are faulty, causing the whole structure to collapse from the inside out? We're looking at a huge macro failure of defense and a tiny micro failure of construction.
All right, let's jump into our first story. This is about the immune system. I want you to imagine it's like a city's police force, always on patrol, keeping things safe. Now, HIV is a very, very cunning infiltrator. It doesn't just attack the constables on the street. Oh no, it goes straight for the top, straight for the police commissioner's office, and in our body, that's the CD4 positive T cell.
So what happens when you take out the police commissioner? Ray, it's total chaos. The entire command structure just falls apart. All the little gundas and chores, the petty criminals that the police force would normally handle easily, they are now free to run wild. The body becomes a lawless state.
And these are the criminals I'm talking about. You've got fungi like Candida causing horrible oral thrush, viruses like CMV that can attack the eyes, bacteria, especially tuberculosis, which is a huge problem for us here in India, and even protozoa causing terrible diarrhea. All these organisms are normally kept in check, but in a patient with AIDS, they completely take over.
Now hold on, it's not just about infections. Look at this number, 25 to 40%. This is the estimated chance that an untreated person with HIV will get cancer. That's a staggering figure, isn't it? Why? Well, because the police force doesn't just fight criminals from the outside, it also keeps an eye on rebellions happening inside.
So the really crucial point here is that this failure of immune surveillance allows other villains to pop up. These are cancer-causing viruses, what we call oncogenic viruses, Epstein-Barr virus, human herpes virus 8, HPV. These guys are just sleeping in many of us, you know? Our T cells keep them suppressed, but in an AIDS patient, they are unleashed, and they lead to really aggressive cancers like Kaposi sarcoma and B-cell lymphoma.
So we've seen a catastrophic failure at the level of the whole system. Now let's shift our focus. Let's zoom in, way in, down to the smallest, most fundamental level, the molecular level. Our second story is about a protein problem, a disease called amyloidosis. Let me give you an analogy. Imagine your body is building a house, okay? And proteins are the bricks. Normally, these bricks are perfectly shaped, they're strong, they're soluble, but in amyloidosis, the brick factory starts producing, well, junk. Faulty, misshapen, sticky bricks. These are our misfolded proteins. You can't build with them, so they just get dumped outside the cells, piling up like a garbage heap and slowly crushing the life out of everything around. Okay, so let's walk through how this happens. It all starts with an abnormal protein. This protein then misfolds. It gets stuck in this very particular, very stable shape called a beta-pleated sheet. Think of it like superglue. It makes it incredibly resistant to being broken down. These misfolded, sticky proteins then clump together, forming these long, insoluble threads we call fibrils. And finally, these fibrils, this gunk, gets deposited in the spaces between your cells, slowly and silently crushing the life out of your organs.
Now, I need your full attention here. This is a critical point for your exams. Amyloidosis is not a single disease. The term amyloid refers to the depositor material, the gunk, but the faulty brick can come from many different sources.
Identifying the specific protein, the specific type of amyloid, is absolutely crucial for diagnosis and treatment.
Just look at this table. You can see there are several main types. The most common is AL amyloidosis, where the problem is an immunoglobulin light chain produced by abnormal plasma cells. Then you have AA amyloidosis, which is secondary to chronic inflammation, like in rheumatoid arthritis. And finally, there's ATTR amyloidosis, from a protein called transthyretin, which can happen just with old age or because of some genetic mutations.
Okay, so we have this bad cement, this protein gunk, piling up. But where does it go, and what damage does it actually do to the patient? Let's look at the main targets. The kidney, the kidney is its #1 favorite target. The amyloid just clogs up the delicate filters, the glomeruli. This leads to massive protein loss in the urine, that's nephrotic syndrome, and eventually total renal failure. The heart is another major target. It becomes stiff and hard. It can't pump properly. The spleen, liver, and even the tongue can be affected, becoming all enlarged, firm, and waxy.
All right, let's go to the microscope. This is a slide of the liver, and it's stained with a special dye called Congo red. Under normal light, you can see this amorphous, eosinophilic, this pink-red substance. It has a glassy, homogeneous look. That is our amyloid, deposited in the walls of the blood vessels and in the space of Désay, slowly strangling the hepatocytes. Just take a moment to see how it's infiltrating all the tissue.
But this is just the first step. The real confirmation, the magic trick, happens when we look at the same slide through a polarizing microscope. And voila, look at that. The classic, unmistakable, apple green birefringence. This is pathognomonic butchologue. Never ever forget this. This image will get you the diagnosis in your practicals and in the clinic. It's beautiful, isn't it? In a terrifying sort of way.
And this is what that damage looks like up close. This slide shows a kidney glomerulus, or well, what used to be a glomerulus. The entire delicate filtering structure is gone, just obliterated, replaced by these massive confluent pink ribbons of amyloid. Now you can connect the histology to the clinical picture of renal failure. The machine is completely and irreversibly broken.
So today we've seen 2 stories of collapse, a breakdown of law and order in AIDS, and a failure of construction in amyloidosis. The textbook and the slides make it look so clear, don't they? But in a real patient, the signs will be subtle. A little swelling, some weakness, vague complaints. So I leave you with this question. How will you, as a future doctor, connect those subtle clues to these massive underlying failures? That is your challenge.